Hello, my name is Ian McCall, and this is another of the consultations in dermatology from the Australian Institute of Dermatology. Today we're going to talk about herpes zoster, but we've entitled it a painful rash, because often it's the pain that presents before the rash does. And the rash is found in a very peculiar distribution. It's seen in the distribution of a peripheral nerve. So often it's confined to what are called dermatomes. And these are areas of the skin that are supplied by one peripheral nerve, or one segment of a sensory nerve that comes out from what's called the dorsal root ganglion at the spinal cord. Why does it come in this particular distribution? Because the virus that causes this condition is to be found in the dorsal root ganglion. And I'll show you a picture of this in a minute or two. But the dorsal root ganglion is adjacent to the spinal cord, and it houses all the sensory nerves. And the virus is imprisoned there for many, many years. In fact, it may have been acquired 60 years before, and it's acquired as chickenpox. It's when you have chickenpox as a child, you don't completely eliminate this virus. Some of it remains in the dorsal root ganglion, and it's held there by your immune system in a sort of quiescent stage. And then 60 years later, or more, sometimes an awfully lot earlier, but often when your immune system wanes as you get older, or you're on drugs that are going to affect your immune system, or you have a disease that affects your immune system, then your immune system wanes, and this virus can then replicate in the dorsal root ganglion and travel down the peripheral nerve into the skin, where it proliferates and gives you the rash of herpes zoster. But as it comes down the nerve, as it proliferates in the dorsal root ganglion, that's when it activates the sensory nerves, and hence you have the pain. And this pain can be on the anterior chest wall, simulating a myocardial infarction. It can be coming down the leg, simulating sciatica, as if you've got a prolapsed disc. And it can be also seen in the abdominal wall, simulating an intra-abdominal emergency. And it's not the first patient that's had their stomach opened looking for something in the abdomen, when in point of fact it's been herpes zoster that's going to come out a day or so later on the skin of their abdomen. So this is a most interesting virus, one that you acquire in childhood and that stays with you for the rest of your life. Let's have a look at some of the slides. But today we're going to do this as a PowerPoint presentation. Now this is just a close-up of the image that I've been showing you. You can see this background redness, and there are some little vesicles, tiny little fluid-filled vesicles that are starting to appear on that red background. Now this patient's had pain in this distribution for 24 hours or more with nothing to see, and then an area of redness will come up, and then the little vesicles will appear. The characteristic of this rash, though, is that it only occurs in one side. In other words, it's affecting the dorsal root ganglion here, and it comes all the way around the front, and this is the dermatome, the area of skin that's supplied by that nerve. Look how it just reaches the midline, hardly crosses the midline at all. And it'll be the same in the anterior side. And this is so characteristic. If you see something like this, it's this pain and this distribution, it's herpes zoster. This is the same patient 10 to 12 days later, because after these vesicles dry up, it leaves often a slightly scarred area. Now, those of you who know a bit of dermatology will probably look at this and say, that looks awfully psoriatic. Well, in point of fact, this patient had psoriasis as well. And so when you've got injury to the skin, psoriasis can come up in the areas of injury, the Kobner phenomenon, and that's what's occurring with this man. Here's another patient. Again, pain that was occurring in the neck and the shoulder region, and a few days later, out comes the little vesicles. Some of them then go on and develop pustules, some rupture, form crusts like this. But look at this, look at the midline involvement here. It doesn't cross the midline, but it's going right up into the occipital scalp here, because it's some of the high cervical nerves that are involved, and this is the dermatomes that they supply. Here you're looking at the lateral chest wall of the lady after the zoster has in fact settled down, and you're getting some post-inflammatory hyperpigmentation of the skin. And again, when you see this posteriorly, it only reaches to the midline. But sometimes, of course, it's occurring very early, and in this lady, it's really at a very early stage. But look at the distribution of the lesions here. Upper part of the chest wall and extending down the inner surface of the forearm here. I can never remember my dermatomes properly, but this must be somewhere around T1, I think, rather than the cervical ones. And then if you go on and you do a close-up here, you can see at this stage you've just got the redness occurring, and you've got tiny little vesicles just starting to appear here. And again, only on one side, extending then down the arm. Alas, this is a different presentation. Look how aggressive this is. Look how hemorrhagic the blisters are. But again, only in a certain distribution like this. And when you see this sort of phenomenon in the elderly with hemorrhage into the vesicles and a much more aggressive type of herpes zoster, then you've got to consider that the patient may have some underlying illness that's really affected their immune system, perhaps a leukemia, perhaps a lymphoma, or perhaps they're on drugs that are immunosuppressant drugs for some other condition that they have. So if you see really aggressive herpes zoster coming on in the elderly, or if you see it going out with the dermatomes, spread out with those areas, then it suggests that this virus isn't confined to the nerve anymore, but it's in the bloodstream and it's spreading elsewhere. And this you'll see in an immunosuppressed individual. They can get very severe pain associated with this, as you can imagine, because of the damage to the nerve underlying this. Here's another case, and this image is courtesy of Dr. Prishish Barua. Here's an some underlying erythema. They're at different stages as well here. This one's a bit more advanced. Look, not the sunken dell area in these vesicles. This is characteristic of many of the herpes viruses, and this is herpes zoster, or the chickenpox varicella virus. And as I say, you'll see them at different stages. You can see some down the leg here, so it's coming down this dermatome on the leg. This is a close-up just to show you the little dell that occurs. There's some pus forming in these, that's why they're not clear whether that yellowish color. But here are some early ones here. It's almost like the description of the chickenpox lesion as being, what is it, dewdrops on a rose petal. These are the dewdrops, and this is the pink of the rose petal underneath. Here's another example of this is a patient with chickenpox. This is varicella, the same virus, only in a much younger age group, and these are the lesions that that you get with chickenpox. Here's another classic area where people will get the herpes zoster virus, and it particularly can affect the ophthalmic division of the trigeminal nerve. This is the trigeminal nerve supplies sensation to the face, and you've got the ophthalmic division coming out here in the supraorbital notch, affecting, involving half the face here, right round to half the forehead, right round to this area. There's also involvement of the eyelids here, and this is just edema fluid from the inflammation that's here. If, and unfortunately this one isn't large enough, this image to show you, if you get involvement of the tip of the nose down here, an area supplied by the nasociliary nerve, then that suggests that you're going to get involvement of the surface of the eye, and you may get a keratitis and inflammation here, and it can leave someone blind. So it's very important that these patients see an eye specialist. I mean, just looking at that, you'd think there's going to be eye involvement anyway, and this would be very painful. This is just a close-up to show you how extensive the vesiculation, the vesicles have joined together to form almost blisters here. And this was the picture I talked before of where this virus is. The virus is here in the dorsal root ganglion. This is the nerve that goes out to supply the skin. And here it's here. This is your spinal cord, and it's protected by the vertebrae and the discs in front of the spinal cord. The spinal cord runs up through a space here behind the vertebrae. And this is where the nerve lies. for, as I say, 60 years or more before it gets activated, and it causes some necrosis and damage there, and hence the pain, because this is the sensory end of the peripheral nervous system, and it then goes back down the spinal nerve here into the skin. Sometimes, unfortunately, if you are immunosuppressed and you're elderly and you get zoster, the virus starts to spread, and it looks like chickenpox again. The virus is going via the bloodstream. But if you're immunosuppressed, not only does it go via the bloodstream to the skin, but it can travel to internal organs like the lungs and especially the brain. And so immunosuppressed patients are at grave danger from this type of spread. And it's especially the case in patients who have AIDS or HIV disease, where herpes zoster can disseminate and can kill them. This is an example where it has disseminated, and for all the world, it looks like chickenpox. It looks like varicella, which is what it is. It's the same virus. Just one last example of fairly florid varicella, fairly florid chickenpox. And this is florid. You just don't usually get the vesicles joining up to form big blisters like this. There may be a bit of secondary staph infection causing impetiginous-like blisters when you see that sort of picture. But this is really quite severe. And of course, this type of varicella can give quite a lot of scarring. Just another example of varicella. So, how are we going to treat someone who's got severe varicella zoster? This was just to remind me to talk about zoster immune globulin. This is a vaccine that is prepared from varicella virus, and what it can do is to help stimulate your immunity as you're getting older. It's recommended now for people over the age of 60 who have had varicella when they've been younger, who have had chickenpox when they're younger. But as they go older, their immunity wanes. But the purpose of giving this is to boost that immunity again. And certainly trials that have been done on large numbers of elderly people, it will reduce the incidence of herpes zoster somewhere in the region of 50%. And it will reduce post-herpetic neuralgia by as much as 60 to 70%. And we should talk a bit about post-herpetic neuralgia. Post-herpetic neuralgia is persistent pain arising in the area of herpes zoster. When the zoster is all cleared up and settled, some people get severe pain in the distribution of that nerve. That nerve's been so damaged that they get persistent pain that just goes on and on and on. And it can be severe, especially if it's involving the face, over the eye. It can be a very, very debilitating type of pain. And so treatment, any treatment that can stop you getting that is going to be very useful. How do you treat zoster? Well, you treat it initially with pain relief. Pain relief is important. First of all, a couple of other facts I should have mentioned. The incidence of herpes zoster is mainly seen in people over the age of 60. It can be seen in children. It can even be seen, early on. A child may have had chickenpox at the age of 3 to 4 if they haven't been vaccinated early on, and they may get zoster when they're 7 or 8. You can even very rarely get a baby who's in fact got zoster when they got chickenpox when the mother's got it in pregnancy. The child's had it, and it's then born when it's all clear, but then at the age of 2 or 3, suddenly the young child gets zoster without apparently ever having had chickenpox. But it's usually been when the mother's had it during pregnancy. So rare and funny things like that can occur. But the vast majority of cases of herpes zoster you're going to see are going to be people over the age of 60. Anyway, I digress. Pain relief, very important. You've got to give them pain relief. This is a bad pain. They need Panadol Forte. They may even need some opiates, but I generally try and avoid using that if I can. This is early on with the condition. They need topical ice packs. Calamine lotion sometimes helps. If it's weeping, you can use some borough solution soaks to help to dry that up. The crux of treatment, though, are oral antivirals. And these are the main drugs that we use: acyclovir, famciclovir, and valacyclovir. These affect a thymidine kinase enzyme that's particular for the herpes virus, and it inhibits the herpes virus DNA, so it inhibits the virus replicating. So, and it's very specific. It doesn't affect any human enzyme system. It only affects this herpes virus enzyme. So it's a great drug, but it only works if you give it early, within the first 72 hours. I will give it later than that if I've got an immunosuppressed patient, or if I've got someone who's still got a lot of new lesions coming up. But it's usually, the trials have shown it's mainly effective for people who are given it before 72 hours is up. Famciclovir and valacyclovir are better than acyclovir for herpes zoster, simply because you require lower concentrations. The dose of acyclovir to deal with herpes zoster is about 10 times that's necessary to treat herpes simplex. So these drugs, famciclovir and valacyclovir, are the better drugs for herpes zoster. Other topicals that you can use, well, local anesthetic patches, something that's got lignocaine in it, can help with some of the pain. And later on, if you get post-herpetic neuralgia, this stuff, capsaicin, a substance P inhibitor, cream can be used. Unfortunately, it tends to burn a bit when it's put on, and in my experience, it's not all that helpful. You should treat any secondary bacterial infection that the patient has, although it's often not a major issue, but do a swab anyway and see and treat them if they have secondary bacterial infection. The question of oral steroids in someone with acute herpes zoster is always a vexed one. Now, some people believe it does reduce the incidence of post-herpetic neuralgia. It certainly can reduce the inflammation in the nerve with the virus there, but there's always the risk that it's going to accentuate any spread of that virus. And certainly if the patient's immunosuppressed, I don't know that it's a good thing to do. The other drugs for post-herpetic neuralgia are these. And post-herpetic neuralgia, remember, isn't the acute pain. It's pain that's occurring after the virus has cleared up, where you're just left with the scarring. The drugs that are used are these ones, gabapentin and the tricyclic antidepressants. This isn't working as an antidepressant. It works in other ways with for pain mitigation. And these two drugs are quite useful. But the whole idea is to perhaps not get this problem in the first place. So this is why the zoster immune globulin is something you should consider for your patients who are over the age of 60, because herpes zoster is not a nice condition to get in that age group. Zoster in younger age groups, they don't get as much post-herpetic neuralgia at all, and it's not as big an issue, but in the elderly it certainly is. So, herpes zoster, a condition that unfortunately we still see quite a lot of, and as people get older and as they're on drugs that are necessary for other diseases that are unfortunately going to affect the immune system, are prescribed more often, we're going to see more of this, and we're probably going to see it in its more severe form. So it's important you're able to recognize it early, and also recognize the atypical presentations where you've got pain before the rash comes. So that's why we've entitled this A Painful Rash. Thank you very much.